What's up, Ninja Nerds? In this video today, we're going to be talking about congenital heart defects. This is going to be a two-part series. We're going to have one on acyanotic, which is going to be in this video, and then we'll have another video right after this on cyanotic congenital heart defects. Let's get started though. So when we talk about acyanotic congenital heart defects, they're defects within the baby's heart that does not cause cyanosis. What does that mean? So cyanosis is basically the bluish discoloration of the skin. That's the concept here. In these diseases, they typically do not cause cyanosis, therefore acyanotic. There is a little nuance to that, and we'll talk about it, called Eisenmenger syndrome, but for the most part, these conditions do not cause cyanosis. Now, let's talk about those particular acyanotic congenital heart defects. So we have something called an ASD, that's an atrial septal defect. It's simple. There is a hole within the interatrial septum, and that's causing blood to shunt from the left atrium, the higher pressure system, to the right atrium, the lower pressure system, because blood always likes to go from areas of high pressure to low pressure. So we call this a shunt going from the left side of the heart to the right side of the heart, okay? Now, if you think about that, why would that not cause cyanosis? The reason why is because the left side of the heart is the oxygenated blood, and you're pushing oxygenated blood into the right side of the heart, which is the deoxygenated circuit. And the right side pumps blood to the pulmonary circulation. The problem that causes cyanosis is when deoxygenated blood is getting pumped into the aorta, but that isn't happening in this situation, okay? Remember that. The next one is called a VSD, ventricular septal defect. It's a hole within the interventricular septum that causes blood to shunt from the left ventricle, higher pressure system, to the right ventricle, lower pressure system, pushing oxygenated blood into the deoxygenated right ventricle. That's not going into the aorta though. Okay, so remember that. Next one, PDA, patent ductus arteriosus. In this situation, there is a hole that is staying open. You know, there's a structure in the baby called the ductus arteriosus. It's a hole between the pulmonary artery and the aorta. Whenever the baby is born, it should close off and become the ligamentum arteriosum. But in this situation, it stays patent, open, causing blood to shunt from the aorta, the higher pressure system, into the pulmonary artery, the lower pressure system. So we're shunting oxygenated blood from the aorta into the pulmonary artery. Again, there's no cyanosis in these situations. The next one is the endocardial Cushing defect, sometimes called an atrioventricular septal defect. This one's an interesting one. So it's kind of like a combination of ASD and VSD. So there is an ASD, thus showing this hole between the left atrium and the right atrium. That's where blood can shunt from the high pressure left atrium to the low pressure right atrium. There's also a VSD, where blood can shunt from the high pressure left ventricle to the low pressure right ventricle, all pushing oxygenated into the deoxygenated, not going the other way. The last thing that's big difference here with endocardial Cushing defects is that not only is there an ASD, a VSD, but if you notice the mitral valve and the tricuspid valve, there's only one leaflet there. So we're missing some of the leaflets from the tricuspid and mitral valve. So there's abnormalities within those leaflets as well. The big thing is this whole category here are called your left to right shunts, meaning you're pushing blood from the high pressure left side of the heart, whether it be left atrium to right atrium, left ventricle to right ventricle, or aorta into the pulmonary artery. All of these things, you're shunting oxygenated blood into the deoxygenated circuit. That doesn't cause cyanosis. Where cyanosis comes is when you push blood from the deoxygenated side of the heart, right ventricle to left ventricle, right atrium to left atrium, or pulmonary artery into aorta, but that's not happening. What happens in this situation is you push a lot of blood into the right side of the heart, which pushes a lot of blood into the pulmonary circulation. And the pathophysiology behind this is you get a lot of pulmonary blood flow. And we'll talk about that later. The last one here that's kind of like a little outcast, kind of a random one that we just add into this category of acyanotic, because it would be in an individual video, is it's called an outflow obstruction. We're obstructing the flow of blood into the circulation. And where that actually happens is you have something that's like a little stenotic or narrowed or constriction ring of a particular part of the aorta. And what that does is that obstructs the blood flow down into the lower extremities. And so you get less blood flow down into your lower extremities, but all of the branches of the aortic arch that give blood flow to the head and the arms, you're getting good blood flow to those. So you have this differential type of blood flow, and sometimes We'll talk about this later. You can have shunting because sometimes coarctation of the aorta can be associated with PDAs. And you can get something called differential cyanosis. We'll talk about that later with the Spider-Man dude. But the big thing I need you to understand the difference between these two is these are left to right shunts. This is not necessarily a shunt, it's an obstruction of blood flow into the systemic circulation, particularly where you have higher blood flow in the upper extremities and upper body and decreased blood flow in the lower extremities or lower body. Okay, that gives us the categories, the definitions, if you will. Let's talk about the causes of these different types of acyanotic congenital heart defects. So there's going to be a couple here, 1, 2, 3, 4. What I need you to know, we got patients who have chromosomal abnormalities, 2 types, Down syndrome. So that's going to be one of your trisomy 21s. In that situation, we see Down syndrome associated with these particular conditions: atrial septal defect, ventricular septal defect, endocardial Cushing defect, and PDA. The other chromosomal abnormality, which is within particularly the X chromosome and Y chromosome component here, so somebody has an absent Y chromosome, this is called Turner syndrome. And so they can have that web neck, they can have that shield type of chest, they can have very short stature, they have coarctation of the aorta. So remember, Turner syndrome, coarctation of the aorta; Down syndrome, ASD, VSD, endocardial Cushing defect, and PDA. The next one is when the mother unfortunately drinks large amounts of alcohol. They can develop fetal alcohol syndrome. That can alter the development, the growth of the fetus. And this is a particular one that you can see in patients who develop ASD or PDAs. The next one is your torch infections. So these are intrauterine infections. So we have chromosomal abnormalities, fetal alcohol syndrome, and infections, intrauterine infections, with the emphasis being on one of the components of this torch series. So torch stands for a bunch of different things. You have toxoplasmosis, you have other, you have rubella, you have cytomegalovirus, herpes. There's a bunch of different types of intrauterine infections, but the most important one is the R, and that is the rubella. And so the rubella can actually cause VSDs, but the big one that I really want you to remember that with is the PDA, the patent ductus arteriosus. And the last one here is maternal diabetes. So diabetes within the mother, there is a potential increased risk of ventricular septal defects. So these are the big things to remember for our causes. Let's come down and talk about the pathophysiology of these acyanotic congenital heart defects. All right, so pathophysiology of these defects. So let's talk about the ASDs first. So there's a couple different components here. So first thing is we should have the normal idea of what the interatrial septum is formed by. So there's a couple different types of tissues. We're not going to go into crazy detail here. I just want you guys to get the basic gist. And the normal situation here, you guys see that blue line there? That blue line is actually, there's a septum that grows down to make a part of the interatrial septum. And what I want you to remember is that blue line there is called the septum primum. The septum primum is supposed to basically go through an entire length here from top to bottom. Now what happens is, as it works its way down, 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 it's supposed to get close to this actual septus, the septum intermedium here, which is basically the intermediate portion between the septum of the atria and the septum of the ventricles, okay? But this thing is supposed to go all the way down. That's called the septum primum. As it goes all the way down, it makes a little hole in the top of it called the ostium secundum, okay? Then after the ostium secundum, there's a tissue here that's supposed to come all the way down here, all the way down to the bottom and cover up that ostium secundum. And this is that pink tissue. And that pink tissue is called the septum secundum. Okay, it's called the septum secundum. So you have the septum primum. There's a hole that forms here after it goes all the way down called the ostium secundum. The pink tissue that's supposed to cover that ostium is called the septum secundum. Then normally there's a little hole here in the baby called the foramen ovale. But whenever they're born, that should actually become a little bit more of a scar tissue there and close this area off, becoming the fossa ovalis. So whenever the baby's born, this is what it should potentially be. Now, if you have a defect within the formation of the septum, or you don't actually form the fossa ovalis, what can happen, my friends? So first things first, if the septum primum does not come all the way down, it leaves a defect here on the bottom where blood can shunt. What is that called? Well, it's a defect within the septum primum, so we call that a primum ASD. This is the less common one. The other one is the secundum ASD. What do you think that's an issue with? It's an issue with the septum secundum. It doesn't come all the way down and block off the ostium secundum, so blood can shunt from the left atrium to the right atrium. That causes that left to right shunt. The last one here is called the PFO. Now the PFO is the interesting one. The PFO is because, remember we said that this is a little area right here. It's this little area right here where imagine I actually took like a little probe or something and I ran this probe from this area to this area. That is the patent foramen ovale. Now normally that wants to allow blood to go from the right atrium to left atrium in the baby, right? Because we don't want blood to go to the lungs because the lungs aren't functional. You're in utero, you're in amniotic fluid. The placenta is basically the lungs in this situation. We want it to close though because we want now blood to go towards the pulmonary circuit. But in certain situations, this actual PFO can stay open. And this may seem paradoxical, but the PFO is actually a little bit better at allowing blood, because it acts kind of like this weird little septum. It's actually better at allowing blood to flow from areas of the right atrium into the left atrium. So it's not necessarily kind of like an ASD. It's important to remember that a PFO is actually completely different from an ASD. Those are defects within the septum primum and septum secundum. This is a defect where it actually doesn't fuse between this area and form the fossa ovalis, and so it stays patent, allowing for blood to be able to potentially flow from right atrium to left atrium. Now you might be like, well, Zach, I thought it always goes from areas of high pressure to low pressure. It does. But whenever it tries to go this way, it kind of closes it off. So sometimes what happens is if you get like somebody who develops like a clot, like a DVT, and it gets up into the right atrium, and it gets stuck for a momentary time, and the pressure rises up in the right atrium, it can actually pop that clot over into the left atrium. And then it can go left atrium, left ventricle, get pumped up into the systemic circulation and cause an embolus. And so this is actually called a paradoxical embolus, and you can see this with PFO. So it's a big difference to understand that. Okay, that's our ASD. So I want you to remember, secundum is the more common one, issue with the septum secundum. Primum is the less common one. Now, the next one is your VSDs. Now, the VSDs actually form very interestingly. So here's going to be the ventricles, right? So this is the ventricular wall here. So if you can imagine, this is like the right ventricular wall, this is the left ventricular wall, and we call this portion here, this is like the septum intermedium. Now, what happens is from the apex of the ventricles, you have this blue portion that moves its way up to form a part of the septum. Okay, that's called the muscular portion of the interventricular septum. And then from the septum intermedium, there's this pink portion that comes down, and that's called the membranous component of the interventricular septum. Guess what we have? If you don't form the membranous portion, it's called a membranous VSD, which allows blood to shunt from the left ventricle to the right ventricle. If the muscular portion doesn't completely form, and sometimes this can actually make it a big VSD, or it can be like, sometimes we call it like a Swiss cheese VSD because you can have multiple pieces of it and it just completely malforms. But either way, the muscular portion of the VSD is an issue, and that causes the left to right shunt. It's actually more common to see the membranous VSDs than it is the muscular VSDs. Ooh, okay, we're moving on a roll here. All right, next one is the PDA, the patent ductus arteriosus. So remember I told you, in the baby, there's something called the ductus arteriosus. It's the little hole between the pulmonary artery that I'm tapping on here and the aorta. Normally, the whole purpose is that in the baby, you don't want blood to go to the lungs. And so generally what you do is you shunt blood in this way in the baby, okay? But then what happens is when the baby is born, this should actually close off, because now you don't want this connection to be open anymore. And this closes off. And when it closes off, you now no longer have a connection between the aorta and the pulmonary artery. And this is called the ligamentum arteriosum. But in certain situations, as we talked about above, where someone develops a PDA, it stays open. And then blood can shunt. And remember, which in the baby, when they're born, it's important actually to preface this. When a baby is in utero, what happens? Blood flow doesn't go to the lungs. And so the pressure inside of the pulmonary system is higher because it naturally constricts the vessels because we don't want blood to go to the baby's lungs. And so it's a unique mechanism. And so generally in the baby, the pressure's super high in the pulmonary circuit that we can shunt it from the pulmonary artery into the aorta. That's in the baby when it's in utero. When it's born, what happens is the pulmonary vessels dilate, so now we want blood to go to the pulmonary arteries, and so the pulmonary pressures drop. They drop so much that the pressure inside of the artery is higher than the pressure inside of the pulmonary arteries. And so we know that left-sided pressures are always higher than the right-sided pressures whenever a person's born. And so this causes the shunt to go from the aorta into the pulmonary arteries. So you guys get the point there? So the problem is we don't make the ligamentum arteriosum, we keep it open and we call it a patent ductus arteriosus. Okay, the next one here is called the endocardial cushion defects. So the endocardial cushion defects, remember I told you there's what's called that septum intermedium? And what happens is from the septum intermedium, you actually form a portion of the mitral valve, you form a portion of the tricuspid valve, you form a portion of the interatrial septum, and you form a portion of the interventricular septum. If a patient who actually does not have these endocardial cushions working, there's a defect within the growth of the endocardial cushions, are they going to be able to make the interatrial septum? No. So in this situation, there is no interatrial septum. Are they going to be able to make the interventricular septum? No. So they're not going to have a completely formed interventricular septum. Are they going to be able to have functional tricuspid valve leaflets and functional mitral valve leaflets? No. And so what happens is this allows blood to shunt into the left atrium to the right atrium because higher pressure, and blood to shunt from the left ventricle into the right ventricle because of a higher pressure system. And you can even have reflux into the atria because you don't have functional tricuspid and mitral valve leaflets to block blood flow. That's a terrible situation to see here. Big thing to remember here, going off of these, is endocardial cushion defects. Usually this presents in children of about 6 weeks of age. And same thing, VSD usually presents with children at about 6 weeks of age. The VSD and the PDA and even coarctation of the aorta, they can really present at any kind of time or age in these patients. So remember to, please don't forget that, okay? The next and last one here is that obstructive type. That's the coarctation of the aorta. What happens with the coarctation of the aorta is you form these little constriction rings. And what's really important for you guys to remember is where the constriction ring forms with respect to the ductus arteriosus, if it's in the baby, but if it's supposed to close off, it should be the ligamentum arteriosum, right? So we say, where is the constriction ring with respect to the ductus arteriosus or the ligamentum arteriosum? Or in some situations, they may even have it open, a PDA. So where is it with respect to that structure? So if the constriction ring is before the ductus arteriosus or the ligamentum arteriosum, we call that preductal coarctation of the aorta. What I need you to remember is this is more common in infants. This is the infantile type of coarctation of the aorta. And the problem is that all the pressure, if you're having this blood going through here, the pressure is going to be having to squeeze through this tiny little area here. And so the pressure in this area is low. And guess what? The pressure in the pulmonary arteries actually might be a little bit higher, that it causes blood to shunt into the aorta, causing a little bit of mixing of blood. And so you can get cyanosis of the lower extremities, but have completely like normal blood flow sometimes in certain degrees to the upper extremities, okay? Postductal. A postductal coarctation of the aorta is, if you look at the constriction ring, it is after the ductus arteriosus or the ligamentum arteriosum. This is more common in the adult type. So it's important to be able to remember that. A preductal is infantile, a postductal is adult. Preductal constriction ring before the ductus arteriosus or ligamentum arteriosum, postductal constriction ring after the ligamentum arteriosum or the ductus arteriosus. Okay, I think we got the definitions down. I think we got our causes down, the basic pathophysiology. Let's go over the clinical picture now. All right, engineers, let's move on to the next part. So when we talk about pathophysiology of these acyanotic defects, really I think one of the big things is we're gonna kind of keep the obstructive one, the coarctation of the aorta. Since it's such a random one, we're gonna talk about that a little bit separately. We're gonna really focus a little bit more on those left to right shunts, which if you remember, what did I put there? The primary problem was that it was increasing pulmonary blood flow. We were shunting a lot of blood into the right side of the heart and pushing a lot of blood through the pulmonary circulation. Why can that be a problem? Let's think about it. If you have a lot of pulmonary blood flowing through there, you're gonna have a lot of pulmonary pressures, right? So you're gonna have these high pulmonary blood pressures because you're having a lot of pulmonary blood flow. You push a lot of pulmonary blood into the pulmonary artery, you're gonna increase your pulmonary blood flow and increase your pulmonary blood pressures. If you have high pulmonary pressures, what is the issue with this? Well, think about it. If I'm having a lot of shunting of blood from a VSD over, right, from left ventricle to the right ventricle. I'm having a lot of blood being pumped into the right atrium from the left atrium via an ASD, or combined an ECD, or I'm having a lot of blood shunting into the pulmonary artery via the PDA. All of those things are my left to right shunts. Either way, the end result is I'm pumping a lot of blood into the pulmonary arteries. I'm increasing the pulmonary artery pressures. I'm increasing the leaking of blood out of the pulmonary capillaries. If I cause a lot of fluid to leak out of the pulmonary capillaries, that's going to cause edema, pulmonary edema, and that's going to alter the gas exchange process, leading to dyspnea, to tachypnea, so the babies can actually be short of breath. On top of that, imagine you having a lot of fluid that's accumulating within the lungs. It's congesting the lungs. It's causing them to become more fluid and waterlogged. It's harder to be able to clear infections within those lungs. And it increases the risk of bacteria thriving, that it can cause recurrent bronchopulmonary infections because of the congestion of fluid. That's a big thing to remember. Here's another one that's really interesting. I'm supposed to have a lot of blood flowing through the pulmonary circulation. But think about it, the right side of the heart is getting overloaded with blood. It can start to fail. If it starts to fail, where's that blood going to backflow? Into the liver. And this is one of the few signs that you can see of right-sided heart failure, which is hepatomegaly. It commonly, babies don't present with ankle or pedal edema. They rarely present with jugular venous distension. They may present with some puffy eyes, but the most common clinical feature for that right-sided heart failure is sometimes just a swollen type of liver or hepatomegaly. That's some of the things to think about. So they can develop right-sided failure because of the high pulmonary pressures and lots of fluid accumulation, pulmonary edema. The fluid logging causes bacteria to thrive, harder to clear them, and recurrent bronchopulmonary infections, okay? Next thing here, because of those high pulmonary pressures, think about what is the kind of like an indirect result of this. Remember, every single time you're supposed to be getting blood from the pulmonary veins that go into the left atrium, right? So it's supposed to come into the left atrium. So my left atrium has this blood. If some of that blood is getting shunted over into the right atrium, I'm losing volume that I'm supposed to be putting into my ventricle. If I'm getting volume into the left ventricle, but I'm shunting some of it into the left ventricle, or if I'm supposed to be pumping blood into my aorta, but I'm shunting it into the pulmonary artery, either way, I'm reducing filling of the left ventricle, I'm reducing the amount of volume of blood that's being pushed out of the left ventricle, and I'm reducing the amount of blood that's filling the aorta because I'm pushing it all into the pulmonary trunk, or some of it into the pulmonary trunk. You get the point here, right? I'm really reducing the total cardiac output. So the amount of blood that's getting pumped out of the heart into the systemic circulation is lower because I'm either shunting it from the left atrium to the right atrium, shunting it from the left ventricle to the right ventricle, or shunting it from the aorta to the pulmonary trunk. That's dropping my cardiac output. If you drop your cardiac output, you drop your blood pressure. You don't perfuse tissues. And one of the big things is the baby's skin. They start to look pale. They have cool extremities. That's one of the big things. The other thing, and this is one of the really interesting ones, is whenever your blood pressure drops, you create a sympathetic reflex. It's basically your body saying, hey, the blood pressure's low, we gotta up the blood pressure somehow. So your sympathetic nervous system kicks in. And one of the things it does is it says, hey, I'm gonna increase the heart rate. And so it increases your heart rate. And trying to increase heart rate, you try to increase cardiac output to try to increase blood pressure. But then the baby's heart rate is just flying. On top of that, sometimes you try to increase the respiratory rate, hoping that you can actually increase the actual oxygen delivery into the bloodstream. But it doesn't actually help, it just makes them tachypnic. On top of that, whenever you have a high sympathetic overflow, it causes the sweat glands to be stimulated, and they cause a lot of diaphoresis. Here's what's really interesting though. Whenever there's a lot of sympathetic activity, it can actually cause the patient to become more fatigued over time. And especially babies, the way that they present with fatigue is they don't have the correct amount of energy to be able to eat. And so they have poor feeding and then sometimes a failure to thrive. So these are big things to think about that these patients can present with. And this could be kind of a left-sided heart failure type of thing, where they're not being able to generate enough cardiac output because they're shunting all of it into the right side of the heart, increasing the pulmonary blood flow and pressures. But they're dropping their pressures, not perfusing the skin, and creating these sympathetic reflexes. So don't forget that. Okay, on to the next part, and this is the worst case scenario for these babies who develop acyanotic congenital defects. If they have this is the big thing to remember. Usually you won't see this with like small ASDs. You really see this with big VSDs, endocardial cushion defects and sometimes pretty big PDAs. You can get something called Eisenmenger syndrome. If I were to really think about the most important one to remember, it's really large VSDs. That's the big one that can lead to this. But with Eisenmenger syndrome, what happens is you're constantly pushing blood into the right side of the heart. And if you're filling the blood in the right side of the heart, whether it be via the PDA, the ASD, or the VSD, but I'll put most of my emphasis on the VSDs, large VSDs, you're pushing large amounts of volume into the actual right side of the heart. The right side of the heart is going to have to respond to that. And what it does is it starts trying to thicken and become stronger. And so it leads to right ventricular hypertrophy. On top of that, here's where it gets really interesting. Do you see these pulmonary vessels here? Whenever the pulmonary vessels are on under high pressure, they have to respond. And they do this in a very interesting way. Because we're pushing so much blood into the right side of the heart, whether it be left atrium to right atrium, left ventricle to right ventricle, or aorta to pulmonary arteries, all the pulmonary vessels are getting filled with blood. When they get filled and filled and filled with all of this blood, they can't tolerate that high pressure for long. So they have to protect themselves. And what they do is they undergo an intense reactive vasoconstriction. So they're going to constrict their vessels. That's the first thing. Second thing is they're going to thicken the walls of the vessels. When you vasoconstrict the vessel, you decrease the lumen. And when you thicken the vessel, you again cause this peripheral vascular resistance, the amount of resistance to blood flow through that pulmonary vessel, to jack up. So the pulmonary vascular resistance is going to increase significantly. So if the pulmonary vascular resistance in these vessels increases, now the right ventricle is going to have to work even harder to pump blood into it. And you know what's really interesting is normally our left-sided pressures are supposed to be higher than our right-sided pressures. We know that left ventricular pressure should be higher than right-sided, left atrial pressure should be higher than the right atrial pressure, aorta should be higher than the pulmonary artery. This is something that we know. But if under a long period of time you cause that peripheral vascular resistance to increase so much, the right-sided pressures can actually start overcoming the left-sided pressures. And when that happens, you now reverse the shunt. If the right atrial pressure is higher, you start shunting blood from the right atrium to the left atrium. That's putting deoxygenated blood, represented by blue, into the oxygenated chambers of the heart. That can lead to cyanosis. I push blood from the right ventricle into the left ventricle. I'm pushing deoxygenated blood into the oxygenated chambers. If the pressure in the pulmonary artery is high enough, it can shunt blood into the aorta. That's pushing deoxygenated blood into the oxygenated vessels. What happens now is I'm pushing all of this deoxygenated blood into the oxygenated chambers of the heart, the left atrium, left ventricle, and the aorta. Now the actual arterial system is getting less oxygenated blood because of this right to left shunting. When this happens, when you go from a left to right shunt and you switch it over to a right to left shunt that causes cyanosis, this is called Eisenmenger syndrome. And it's because you put so much blood flow into the pulmonary vessels, it had to respond. Vasoconstrict, thicken the walls, increasing resistance, causing the pressures on the right side of the heart to overcome the left pressures, and now switch and reverse the shunt. Right atrium to left atrium, right ventricle to left ventricle, and pulmonary artery into the aorta. And now we push deoxygenated blood into the oxygenated circuits. When that happens, you start to see this effect of cyanosis. So what can this look like? Now I got a mixture of oxygenated blood and deoxygenated blood moving into my systemic vasculature. One of the big things is it presents with the cyanotic findings. Bluish discoloration of the skin, the lips, the oral mucosa, sometimes the sclera, all over the body. And these are the big concerning findings, especially like central cyanosis. The next thing is over a long period of time, more of a chronic finding. The nail beds can actually become huge. Your fingers can look like spoons. And this is called clubbing of the digits. The other thing is if you put a pulse oximeter on, you'll notice that their pulse ox, the saturation of oxygen is much lower because we have a mixture of deoxygenated, oxygenated blood going through the systemic vasculature. The other thing is whenever you have low oxygen levels within the blood, the kidneys do not like that. And the kidneys respond and say, hey, if there's less oxygen, maybe it's a problem because I have less red blood cells, but that isn't the issue. It's the problem with the heart. And you know what it does? the kidney gets stimulated and it says, I'm going to release erythropoietin, EPO. EPO tells the bone marrow, make more red blood cells, because if we have more red blood cells, we can pick up more oxygen, deliver more oxygen to the tissues. But that is not the issue. It's the problem with the actual oxygen being mixed between the chambers of the heart. But nonetheless, this will happen, and you'll try to make more red blood cells. So one of the findings of these babies is that they will have high numbers of red cells within their hematocrit, and this is called polycythemia. These are the big findings that I need you guys to remember for Eisenmenger syndrome, which is the reversal of the left to right shunt, now becoming a right to left shunt. Woo, okay, let's move into the next thing. If we go through these and we talk about, these are all of the findings, right, that we talked about that can happen with the left to right shunts, okay? Let's talk about some of these left to right shunts and some more specific clinical features that you have to know for your exam. For the ASD, when you're actually taking the stethoscope, listening to the chest, what are some things that you can find? So we know we have an S1, which is the closure of the tricuspid and the mitral valve, and then you have the S2, which is the closure of the aortic valve and the pulmonary valve, thus represented by A2 and P2. It's the second heart sound composed of aortic and pulmonary valve closure. When someone has an ASD, they have three particular findings. One is they have a systolic ejection murmur. What does that do to? Think about this really simply. You have an ASD, you're pushing blood. We haven't had Eisenmenger syndrome. We push blood from the left atrium into the right atrium. You fill the right ventricle more. If you fill the right ventricle more, you pump more blood into the pulmonary vasculature. If you pump more blood into the pulmonary vasculature, you're having a higher velocity of blood flow flowing through the pulmonary vessels. That's going to cause turbulence of blood flow. That precipitates a murmur, and that is the systolic ejection murmur. Okay? It's due to high pulmonary flow. The other thing is you develop a fixed split S2. That's basically saying that if you have more of blood that's going from the left atrium to the right atrium down to the right ventricle, now the right ventricle has more blood than usual. It already takes a decent amount of time for it to get all the blood out into the pulmonary vessels and then close the pulmonary valve. It usually always closes after the aortic valve. But now you fill it with more blood. And if you fill it with more blood, now it's got to pump all of that blood out, which is going to take longer, and then it's going to take longer for the valve to actually close even more. So now it's splitting the actual S2. The P2 component becomes even further away from the A2. But here's the thing when we say fixed. It doesn't change during inspiration or expiration. It stays the exact same, okay? That is the big thing to remember for this one. The last thing is you get this diastolic rumble. And the whole point here is that as I'm pushing lots of blood from the left atrium into the right atrium, I'm having more blood flow across the tricuspid valve. If I have more blood flowing across the tricuspid valve from the right atrium into the right ventricle, that causes a rumbling sound as it moves across the tricuspid valve. And that is called the diastolic rumble. And we hear the tricuspid valve at that left lower sternal border. And so that's why we have that one. Boom, roasted. VSD. For the VSD, you have again S1, closure of the tricuspid and mitral, and then S2 is the two components here, closure of the aortic valve and the pulmonary valve. In this situation, you have a holosystolic murmur. That means that you can hear the murmur the entire time. Real quickly though, actually before we come back to this, there's another thing here with ASD which is important to remember as a separate complication. We talked about it a little bit before, but you can see this with particularly more specifically PFOs rather than ASDs, but I thought I'd mention it here because sometimes you can see this with really large ASDs, or if someone has a DVT and they actually break off a piece of that DVT, it comes up the inferior vena cava into the right atrium, it can actually quickly jump over from the right atrium to the left atrium into the left ventricle, and you can pump that up into the systemic circulation up to the brain and cause strokes. You see this primarily with PFOs, but with very large ASDs, sometimes you can see this. Okay. Back to the VSD. With this one, again, you have holosystolic murmurs. What is a holosystolic murmur? It means you hear the murmur throughout the entire time period of systole. All this is in VSDs, you're having a lot of blood flowing from the left ventricle into the right ventricle, and it's going to be bouncing off of the walls of the right ventricle. That creates a turbulence of blood flow. That turbulence creates a murmur. And this happens because when the left ventricle contracts, it generates more pressure to push blood into the right ventricle. And so that's how you get the holosystolic murmur. It's important to remember, though, the smaller the defect, the louder the murmur, because we know that small diameter causes more velocity. More velocity causes more turbulence. More turbulence makes the murmur louder. So large VSDs, softer. Smaller VSDs, louder. Remember that. Okay, so holosystolic murmur is due to the VSD. And then we have a loud S2. Think about this. If I'm pushing a lot of blood into the right ventricle, I'm pushing a lot of blood into the pulmonary arteries. The pulmonary artery pressure is going to be much higher. Whenever the pressure in the arteries are higher, it snaps those pulmonary valves shut really, really hard. And so it shuts them hard, and it actually causes the P2 component, the closure of the pulmonary valve, to be a lot louder than it usually is. And that's why we get a loud S2, but particularly the P2 component is what's the actual component that's actually causing that loud S2. Because of the high pulmonary pressures, because we're pushing a lot of blood into the right side of the heart, pushing a lot of blood into the pulmonary arteries, increasing the pulmonary artery pressures, which is shutting the pulmonary valve closed really hard. The last thing is you have a diastolic rumble. So you're like, oh, okay, that's interesting. Why is this happening? Here's why. This one's interesting. You're pushing a lot of blood from the left ventricle into the right ventricle. A lot of blood into the pulmonary arteries. A lot of blood from the pulmonary arteries goes back into the pulmonary veins. From the pulmonary veins, they all empty into the left atrium. The left atrium is going to have a ton of blood flowing across the mitral valve. If you have a ton of blood flowing across the mitral valve during diastole, it's going to cause the rumble. But the rumble will not be at the left lower sternal border. It'll be at the apex where you actually have the mitral valve. Pretty cool, right? All right, so that's the different components of the VSD. Let's now come down and talk about PDA, endocardial cushion defect, and then finish this off with coarctation of the aorta as kind of its own separate entity. All right, so the next one is patent ductus arteriosus. So what happens with this one? The real big thing here to remember is, as we kind of like seeing here, systolic ejection murmur is the big things, fixed split S2, diastolic rumble. For that one, holosystolic loud S2, diastolic rumble at the apex. For PDA, it's really the easiest one to remember. It's a continuous murmur. So you hear that throughout systole and throughout diastole. So if you look at it, it actually has more of a crescendo type of fashion that you hear, because as you're having a lot of blood going into the aorta, a lot of it's shunting into the pulmonary artery. So it's going to be having a lot of blood moving through that actual ductus arteriosus, the patent ductus arteriosus. But it's still going to be moving through during diastole. And so you have this continuous machinery sounding or machine-like murmur. That's the big telltale sign, buzzword term that you have to remember. Now let's understand, why is it continuous? Okay, we know that the left-sided pressures are higher than the right-sided pressures, but maybe what you didn't think about is that during systole, the aortic pressure is still higher than the pulmonary pressure. During diastole, the aortic pressure is still higher than the pulmonary pressure. And I think that is what's really interesting, is that the aortic pressure is always higher than the pulmonary pressure, regardless of when the heart is in systole or when it's in diastole. So because of that, blood always flows from high pressure to low pressure. So in this time, guess what's happening? Blood is shunting where? From the aorta into the pulmonary artery during systole. During diastole, blood is shunting into the pulmonary artery during diastole. And that's why you get that continuous murmurs, because the pressures are always higher in the aorta than in the pulmonary artery during systole and diastole. Pretty darn cool. Okay, the other thing here is, again, think about that PDA here. Another important finding is called wide pulse pressures. So imagine here the left ventricle pumps a lot of blood into the aorta, right? So when you pump a lot of the blood into the aorta, and then actually during the systolic process, you get this point here. This is your systolic blood pressure, this peak point here, okay? Then what happens is blood flows into the aorta, you go through a relaxation period. When the heart goes into a relaxation period, the actual pressure in the aorta should drop down to about 80, and we're going to call this the diastolic blood pressure, okay? But remember, what did I tell you? The diastolic pressure in the aorta is always going to be higher than the pressure within the pulmonary vessels. And so blood will actually shunt into the pulmonary arteries a decent amount during diastole. And what happens is, because it's shunting into the pulmonary arteries a lot during diastole, your diastolic pressure drops pretty low and your systolic pressure stays high. And so in these patients, they have these wide pulse pressure findings, high systolic blood pressure and a low diastolic blood pressure, because during diastole, the aorta is shunting a lot of blood from the aorta into the pulmonary artery. And that's dropping your diastolic pressure in the aorta because you're shunting it into the pulmonary artery, therefore causing the difference between the systolic and the diastolic to be extremely large, or wide in this case. So that's one of the big things to think about. Okay, endocardial cushion defect is a super random one. It's relatively easy to remember this one. You want to know why? Because it has all the findings of an ASD, all the findings of a VSD. So because of that, you would have a holosystolic murmur at the left lower sternal border. That's because of the VSD, okay? You would also have a holosystolic murmur at the apex. This is why it's different. Remember, I told you that in these patients, they don't have great complete valves. So you see how we're missing that one leaflet of the mitral valve, like the anterior leaflet of the mitral valve? Because of that, it's easy to pump blood right into the left atrium. And because of that, you're going to push a lot of blood into the left atrium during systole. It can cause a holosystolic murmur that is also present at the apex, and this is mitral regurgitation. That's a big one to remember. And then you get the systolic ejection murmur here, because again, you're pushing a lot of blood in from the left atrium into the right atrium down to the right ventricle, or you're pushing a lot of blood via the VSD into the left ventricle into the right ventricle. You're filling up the right ventricle, pumping a lot of blood into the pulmonary circulation. If you're pumping a lot of blood into the pulmonary circulation, high velocity is going to cause turbulence of blood flow and cause a systolic ejection murmur, because you're pushing a lot of volume of blood into the right side of the heart. Therefore, you should get a systolic ejection murmur. Don't forget that. So all of these can be particular findings that you would see during systole. And again, because you have an ASD, you're going to be pumping blood from the from the left side of the heart into the right side of the heart. You're overflowing the right side of the heart. If you overflow the right side of the heart, it's going to cause it more time for it to be able to contract and push all the blood out into the pulmonary artery, which is going to cause the pulmonic valve to close later. When it closes later, it splits the actual second heart sound, and the P2 comes way later than the A2. And because it does not change during inspiration or expiration, it is fixed. So again, you can see a lot of the findings of a VSD and an ASD, with the only kind of additional thing here is you can also see the holosystolic murmur at the apex, and that's because you don't have a well-formed mitral valve leaflet and you can blow blood back into the left atrium. So these are big things to think about for the endocardial cushion defect. Let's come over here to the last one here, which is for all of this part here for the coarctation of the aorta. When we talk about the coarctation, remember I told you there's two types. There's the preductal, that's going to be this diagram that we're going to talk about. And then there's the postductal. This is the one we're going to talk about here. What happens is with a preductal type of situation here, a preductal coarctation, what does that mean? That means that the constriction ring has to be in front of or before that little pink tube, the PDA, the ductus arteriosus, the ligamentum arteriosum, right? So because of that, imagine here what happens. You have the left ventricle, it's going to pump blood into the aorta, and you're going to have all this oxygenated blood going to the right side of the body, to the head, going up to the head, maybe even getting into the left arm, but then, ooh, I'm hitting this little constriction ring where I can barely get any blood to squeeze through that tiny little constriction ring. And then I'm going to have very little blood that's going to be going out to my lower extremities. So a lot of blood going into my upper extremities, head, neck, all of that, but less blood flow going into my lower extremities. Guess what? If the baby has a PDA open, guess what happens? Blood from the right atrium goes to the right ventricle, from the right ventricle to the pulmonary artery. Think about this. I know this may seem a little odd. If I have very little blood going into this aorta, what do you think the pressure is in that little segment there right after the constriction ring? Do you think it's high or low? I'm not getting a lot of blood in that area, so it's going to be low. But the pressure in front of that constriction ring, holy mama, it's going to be super high. I'm going to have very high pressure in front of the constriction ring, but low pressure after the constriction ring. So if the pressure in that little segment there is low, it's going to be easy for blood to flow from the pulmonary artery via the PDA into the aorta. And then now I'm bringing more blood flow down into the lower extremities, but I'm bringing a mixture of decreased oxygenated blood and normal oxygenated blood. There's a mixture there. There's a mixing of blood. And because of that, my upper extremities will get normal oxygenated blood. There's no shunting of this prior to that constriction ring. So all oxygenated blood will go up to my head and my arms, thus represented here on the Spider-Man looking dude with the red blood, all oxygenated blood to my upper extremities and my head and neck. But then, after the constriction ring, all of this blood now from this part of the constriction ring afterwards and down is getting a mixture of oxygenated and deoxygenated blood. So now my torso and my lower extremities are getting way less blood that is actually completely oxygenated, and now it's mixed. And because of that, we call this differential cyanosis. And this is something that you can see in a infantile or preductal type of coarctation of the aorta, is they can have differential cyanosis. Cyanosis of the lower extremities and kind of the torso, and then normal oxygenation, no cyanosis or bluish discoloration of the upper extremities, head and neck. And that is important to remember. The other thing that can happen here is because you have this little constriction ring, imagine I'm trying to push blood out of the left ventricle into the aorta and through that tiny little constriction ring. If I try to squeeze blood through that tiny little constriction ring, small diameter, high velocity causes turbulence of blood flow. That's going to cause a murmur. And it's going to be during systole, and guess what? It's a systolic ejection murmur. And when you hear it, it's because it's squeezing through that tiny little stenotic area, and the textbooks say that this commonly is heard on the left posterior hemithorax. And again, think about it because you're squeezing blood through the tiny little constriction ring. All right, so the next part here is the postductal coarctation of the aorta. So again, this is what you're going to see in the adult type. So what I really want you guys to think about here is postductal. What does that mean? So if we think about it, it's where the constriction ring is with respect to the ligamentum arteriosum or the ductus arteriosus. It has to come after. So there's our little constriction ring. What is the problem with this one? So the problem with this one is here's our left ventricle, right? It pumps blood into the aorta. From the aorta, it's able to pump a good chunk of blood into the vessels off the aortic arch that go to the upper body. So to the head, the neck, the upper extremities, all of those are getting well perfused. They're getting a good chunk of blood flow. So because of that, their actual pressures in the upper body tend to be very, very high because this constriction ring is narrowing the amount of blood that can get into the lower extremities. And so the pressure just proximal to that little constriction ring is going to be crazy high. And then the amount of blood that's getting down into the lower extremities, you're not getting a lot of blood because I got to squeeze the blood through that tiny little constriction ring. And that's going to drop the pressures that are going down and perfusing the lower part of the body. So there's very high blood pressure and perfusions to the upper body and very low blood pressure and low perfusion to the lower body. Now, why is that a problem? Think about it. If you have very high pressures that are going to be going up into the brain, it can cause headaches. It can cause an actual abnormal ringing sensation of the ears called tinnitus. On top of that, it can actually cause ballooning of the vessels within the brain. And these are called Barry aneurysms. And if they rupture, they can increase the risk of like intracranial hemorrhages. And so these are really, really important things to think about because of the high pressure in the upper body. The other thing is if you have a high pressure in the aorta, now the left ventricle has to work really hard to push a lot of blood into that high pressure aorta. So it has to get jacked up, it has to get thickened. What is that called when it has to get thickened and so it can pump harder and push more blood into the aorta? That's called left ventricular hypertrophy. The other thing is because all the pressure in the aorta is super, super high, they're gonna have high blood pressure. If you take the actual blood pressure and a cuff and actually put these on these arms, they're gonna have super high blood pressures. So they're gonna have hypertension. But the big thing here is because of the high pressures in the aorta and causing the left ventricle to hypertrophy, it's going to cause so much stress, hard work, hard demand of the actual left ventricle that eventually it won't be able to maintain it and it will lead to left heart failure. So that's a big thing to think about. Now, the other thing is if we have low blood pressure, we're not perfusing the lower part of the body. We're not getting oxygen. We're not getting blood flow to the lower extremity muscles. They're going to become very painful. It's going to cause them to not be able to perform their normal contractions, especially when we're trying to exert ourselves. When we exert ourselves, we utilize oxygen within the muscles. And if we have very little supply to those muscles because of the decreased perfusion due to that dang constriction ring, guess what? Those muscles aren't going to get the amount of oxygen that they need and they demand during exertion. And so this can cause a pain in the lower extremities called claudication. Also, if you check the pulses of their lower extremities, they'll have very decreased pulses and sometimes pale and cold extremities of the lower part of the body. So that's a big thing that's important to remember. Another big telltale sign that you'll probably see on your exams is that if you check the blood pressures of their upper extremities, they're going to be high. And then if you check the blood pressures of their lower extremities, they're going to be low. Relatively significant difference here. So sometimes we call that a brachiofemoral delay. The other thing is, if you check, the brachiofemoral delay is also very specific to the pulses. If you check the radial pulse and then you check the actual like femoral pulse and you look at the pulse difference there, the brachial pulse is going to be very bounding and high and more rapid. And then the femoral pulse, which is supposed to come early, you're actually supposed to be able to feel the femoral pulse before you feel like the radial or brachial pulse. In these patients, the femoral pulse comes later, which is not a normal finding. So if the femoral pulse comes later after the brachial or radial pulse, that means that there's some type of delay there, and that's a brachiofemoral delay. So again, seeing a big pressure difference from upper extremities to lower extremities, or delayed femoral pulse coming way later than the actual brachial pulse, that is a huge difference and a big thing to remember here. Okay, so that covers all of the clinical pictures for these acyanotic defects. Let's now hit the diagnosis. So let's talk about the diagnosis of these acyanotic congenital heart defects. So one of the big things to remember is you're going to have three particular tests: an EKG, a chest X-ray, and an echo. To be honest with you, you could potentially not even remember all of the EKG and chest X-ray findings. That is completely fine. I think the biggest, most important, definitively diagnostic test is going to be the echo. You could actually have an even better test in that, which would be cardiac catheterization, but we don't generally do those anymore. They're invasive and they're higher risk, and they don't actually give us as much diagnostic info as we could potentially just, again, obtain with a non-invasive study like an echocardiogram. So, big thing to remember here, you can get a chest X-ray, you can get an EKG. They may be somewhat helpful in the diagnosis, but again, the big, most important test here is going to be the echocardiogram. It's the best test, it's the diagnostic test. Okay. For EKG, chest X-ray, echo, we're going to go through each one of the actual acyanotic defects and try to pick these out. So first thing here for the EKG, on ASD, you're overloading, remember, you're pushing blood from the left atrium into the right atrium, you're pushing blood into the right ventricle. It's going to cause the right ventricle to have more blood. When it gets more blood, it's going to have to try to be able to accommodate. So it tries to undergo hypertrophy. When it undergoes hypertrophy, it tries to make itself a little bit thicker, a little bit bigger. And because of that, you can actually see patients with right ventricular hypertrophy because it's getting thicker, right atrial enlargement because you're pushing more volume of blood into the right atrium. And sometimes as you make the right ventricle thicker and bigger, it yanks and stretches on those right bundle branches, and it can actually cause blockage of the right bundle branches. So that's the big things to see here potentially for the EKG. For the chest X-ray, you're pushing a lot of blood from the right side of the heart into the pulmonary vessels. You're filling these bad boys. And for the most part, for almost all the left to right shunts, ASD, VSD, endocardial cushion defect, and PDA, what do you think is going to be the common theme for all of these on their chest X-ray? Heavy pulmonary vasculature, because you're pushing a lot of blood into them. So that's going to be the big thing that you'll see with that one. And again, because you are pushing a lot of blood from the left atrium to the right atrium, you could make the right atrial border a little bit larger on ASDs. All right, but the big thing is the echo. And if you do the echo and you put on the color Doppler, you'll be able to see the shunt of blood going from the left atrium into the right atrium. For the VSD, again, think about it. Your left ventricle, it's going to be pushing a lot of blood from the left ventricle into the right ventricle. It could potentially thicken the right ventricle over time if it has to work really hard, because the pulmonary vessels are getting overfilled, they're undergoing reactive vasoconstriction, they're thickening their walls, they're making the right ventricle have to hypertrophy, and if it does hypertrophy, that's indicative of Eisenmenger syndrome. But the more common findings is you're pushing a lot of blood via the pulmonary arteries into the pulmonary veins, pushing a lot of blood from the left atrium into the left ventricle, causing the left ventricle to have to accommodate a large volume of blood and have to get thicker. Okay, so it undergoes left ventricular hypertrophy. You're also bringing a lot of blood into the left atrium, so you're going to cause the left atrium to enlarge. And so these would be the particular findings that you would see on the EKG. For the chest X-ray, you're going to see increased vasculature, and you may see enlargement of the left side of the heart, so cardiomegaly. But again, put the Doppler on, look at the blood flow, and look at the shunt going from the left ventricle to the right ventricle, and you got your diagnosis. PDA. You may or may not see left ventricular hypertrophy. Oftentimes, their EKG is relatively normal. So that's one of the big things to think about, is that you may not really see anything very helpful on their EKG. On their chest X-ray though, you'll see a lot of pulmonary vasculature. And again, no right atrial enlargement or anything of that nature. But again, put the actual color Doppler on and you'll be able to see the shunting of blood from the aorta into the pulmonary artery. Okay. endocardial cushion defect. This one's actually really interesting. It's the only one that's just super random. No complete explanation. It may be due to the actual defect within the endocardial cushions and where the AV node is around those endocardial cushions, but these patients tend to have a prolonged PR interval. And again, I would say it's due to some type of defect within the development, potentially the AV node there. But again, they tend to have prolonged PR intervals on their actual EKG. And again, you're pushing a lot of blood from there, left ventricle to the right ventricle. You're pushing a lot of blood from their left atrium into their right atrium, a lot of blood from their left ventricle into the right ventricle. You're overflowing the right ventricle with pressure and volume. It's going to undergo hypertrophy and thickening. Therefore, you may see right ventricular hypertrophy. But again, big thing here that's just pretty much an out of the ordinary one out of all compared to these is that prolonged PR interval for the endocardial cushion defect. So again, I think the big thing here is that the right side of the heart, the right atrium, right ventricular hypertrophy for ASD, VSD, left atrial enlargement, left ventricular hypertrophy, PDA, relatively normal, and then endocardial cushion, prolonged PR. All of these have an increase in pulmonary vasculature, but the most definitive diagnostic test is to see the shunting of blood from the left atrium to the right atrium, left ventricle to the right ventricle, aorta to the pulmonary artery, or looking for any type of shunt of a VSD, an ASD, and abnormal tricuspid and mitral valve abnormalities on their echo would tell you that you have an endocardial cushion defect. Okay, let's come down to the coarctation of the aorta. All right, so the next thing here is coarctation of the aorta, right? So think about this one. For EKG, because you are having higher pressures potentially inside of the aorta, it actually could cause the left ventricle to hypertrophy. So you may or may not see left ventricular hypertrophy. If it's more of like the adolescence adult type, you probably will see left ventricular hypertrophy, but for more of the actual infantile types, you probably won't see anything super obvious. But again, I think one of the big things here that actually differentiates these from all the other chest x-rays is that there's nothing to do with the increased pulmonary vasculature. For this one, you see something very interesting. So you see due to the constriction ring here, when you look at the chest x-ray, because of that kind of constriction ring, it gives like this weird little 3 sign, if you will. And so the little 3 sign could actually be due to the constriction ring that you can see from the coarcted aorta. So that's one particular finding that you can see in the chest x-ray. The next one here is something very interesting. Whenever you have somebody who has a coarctation of the aorta, they're actually not perfusing the distal parts of the aorta very well, which don't perfuse the intercostal arteries as well. And so because of that, you actually get like a diversion of blood flow from like the internal thoracic artery and some other branches coming off of the parts of the aortic arch. And so sometimes it can cause the pulsations of some of the intercostal arteries. And so this can actually kind of chew away at the ribs. And so sometimes you can get something called rib notching. And this is just, again, the whole basic concept here is that because you get decreased perfusion of the descending aorta, you don't perfuse some of the actual branches of the intercostal arteries coming off of that. And so the branches that come off of the other components of the aortic arch, they have to feed those intercostal arteries, and then it starts causing the pulsations of them and starts chewing away at the actual underlying portion of the rib, causing rib notching. So you can see that with coarcted aorta. But again, easy definable thing here is you can get a echo and look to see if you can see a very obvious identifiable stenotic lesion. Another thing that's really important here is sometimes these patients actually have a very high association with a bicuspid aortic valve as well. Okay, so that would be the coarctation of the aorta. That would finish that one off. The last thing here that we should add for these patients with acyanotic congenital heart defects, as well as doing this as just a newborn screening for cyanotic congenital heart defects. So we're covering it here now, but again, this can apply to the same thing when we talk about cyanotic congenital heart defects, is we do something called pulse oximetry testing. When we do pulse oximetry testing, we should also do something called a preductal and postductal oximetry testing. What we do is we take the pulse oximeter and we'll put it on the actual right hand and we'll put it on the right foot. And what we're looking for is we're looking to see if there's a very large difference in the actual O2 saturation between the right foot and the right hand. If there is a really big difference, that tells us that there's some type of potential shunt going on here that's actually causing this cyanotic defect. And so that's a big thing to remember, is that we use this as a part of a newborn screening tool. Again, we're comparing the preductal, the right hand and the postductal right foot. And it just helps us to really kind of identify where the mixing could potentially take place and when we need to go and actually get an echocardiogram of these patients. So again, newborn screening, they automatically get pulse oximetry, right hand, right foot. If there's a large difference, sometimes like greater than 10%, we should follow these patients up with an actual echocardiogram, okay? Now that we've done that, let's talk about treatment. All right, so let's talk about the treatment of these acyanotic defects. So it's actually relatively straightforward, not too complicated. To be honest with you, if they're small defects, especially like ASDs, like if they're really small defects, we typically don't do anything with them because they sometimes will close spontaneously. But if they're really large and they're actually causing symptoms of like heart failure, like we talked about, so they're having right heart failure, they're having some of the concerning signs of maybe decreased left ventricular cardiac output, all of those concerning potential signs of left heart failure, right heart failure, then we should go in and repair that. So if they're very large defects, sometimes like greater than 1 to 2 centimeters, or they're causing symptoms, then we should actually go in and surgically repair that. Or sometimes we actually we'll do like a transcatheter closure, take a catheter, go on the one side, and then just pull, and it creates like a little patch. Pretty cool. VSD, same thing. If it's like small, they're not really causing any problems, they're asymptomatic, they sometimes will close spontaneously. And remember, small VSDs, loud murmurs. Large VSDs, very kind of soft murmurs. But if they have a large VSD and they're actually having symptoms, you should surgically or transcatheterally close that one. The other thing is that sometimes VSDs are more likely to develop some of the actual CHF symptoms because not only are you pushing a large volume of blood from the left ventricle to the right ventricle, you're pushing a large pressure from the left ventricle to the right ventricle. And so sometimes these patients can definitely develop left-sided heart failure and right-sided heart failure. And so you might need to medically treat them in the interim until you can get that surgical closure. And so we would try to maybe do diuretics to pull off some of the fluid if they're developing a lot of pulmonary edema or a lot of actual hepatomegaly. We would actually do afterload reducers so that we can try to push a lot of blood out into the systemic circulation and maintain a good cardiac output. And sometimes inotropes so we can get that left ventricle to squeeze as much blood out of the left ventricle and into the aorta because we just don't want it shifting over into the right side of the heart. So those would be the big things to do. Again, endocardial cushion defects, these ones, they don't actually survive very well. In all these patients, you can't wait, you just need to close them. It doesn't matter if it's small, if it's large, these patients need these surgically fixed. So endocardial cushion defect, it doesn't matter, they have to get surgically fixed. For ASDs and VSDs, if they're small, asymptomatic, they close spontaneously. If they're large, you surgically transcatheterally close them. But for ECDs, endocardial cushion defects, surgery in all forms. It's important to remember that. And again, because you can have large VSDs, ASDs, and valve abnormalities, these patients are at high risk of left and right-sided heart failure. So again, pull fluids off if they have pulmonary edema. Try to be able to reduce the afterload of the aorta so that you can push blood in the left ventricle into the aorta and not into the right side of the heart. And again, inotropes to just maintain a good squeeze of that left ventricle. For the other one, which is the patent ductus arteriosus, the PDA, in that situation, we want to maybe leave it alone if it's a small one. If it's a very small defect, not having any kind of symptoms of heart failure, then okay, we can leave it alone, it'll probably close spontaneously. But for the very large defects or potentially symptomatic or in preterm infants that are having symptoms and issues, we actually should close this. And how can we close this? Really interesting. So there is a molecule called prostaglandin E1. And what prostaglandin E1 does is it actually keeps the duct open. Okay, so it keeps the duct open. In these preterm infants where we actually want to close that duct, we don't want to keep it open anymore, we can actually give them drugs like indomethacin and ibuprofen. You want to know why? You know what happens is arachidonic acid, it's by an enzyme called cyclooxygenase, COX, works to convert arachidonic acid into prostaglandin E1. And prostaglandin E1 keeps the actual duct open. If we give somebody indomethacin and ibuprofen, that inhibits the cyclooxygenase enzyme. They cannot convert arachidonic acid into prostaglandin E1. Prostaglandin E1 levels fall. If they fall, they can't keep the PDA open and it closes. That's a pretty cool mechanism, right? So that's the concept here that we would use in these preterm infants, is that if they're large or they're having any symptoms, we can start them off with indomethacin and ibuprofen, and then eventually surgically close it. Okay, so PDA, if it's small, asymptomatic, leave it alone, likely will close spontaneously. If it's large or they're having symptoms, in preterm infants, we can do indomethacin, ibuprofen to inhibit the cyclooxygenase, drop the prostaglandin E1, and start trying to close it. And then if that doesn't work, maybe 6 to 12 months later, we'll surgically close that, okay? There's a really, really important point here that we have to talk about. Sometimes PDAs can keep certain patients alive. That may seem super weird, but it's important. In certain types of cyanotic congenital heart disease, we actually want to keep the PDA open because it might be the only thing that's keeping the baby alive, because it's helping with mixing of blood. And we'll make more sense of this when we get into the cyanotic congenital heart disease lecture. But what I want you to remember for right now, to just trust me, is that we would keep the PDA open by increasing that prostaglandin E1 level. So prostaglandin E1 level keeps the PDA open. Give them infusions of prostaglandin E1 to keep that bad boy open. And if you do that, you would be keeping it open for certain types of conditions, and we'll explain these in that lecture. But the conditions I need you to remember is a coarctation of the aorta, because if you remember, we talked about this just a little bit ago. The coarctation of the aorta, they're getting no blood flow to their lower extremities if they have a very bad coarctation. You can at least get some blood flow into the aorta. Even though it may be deoxygenated, you're still getting blood flow to the lower extremities, and that is important. So in a coarctated aorta, we need that. Another condition called transposition of the great arteries, another one called hypoplastic left heart syndrome, another one called total anomalous pulmonary venous return, and tricuspid atresia. I know this may seem like very random and like useless information and just bare memorization right now, but I promise we will make sense of it in the congenital heart disease lecture. But these are the conditions you have to keep the PDA open, because it might be the very thing that keeps them alive long enough to get these things surgically fixed. Okay. The last one here for these actual diseases, and we'll talk about the complication of how we treat that very scary Eisenmenger syndrome, is coarctation of the aorta. So for the infantile type, what was that one? The preductal. The constriction ring comes before the ductus arteriosus, the PDA, the ligamentum arteriosum. In those situations, what did I tell you? Keep that dang PDA open so you can perfuse their lower extremities. Even though it's low oxygenated blood, you're still getting some perfusion. We need that. So you keep the actual the PDA open by giving them prostaglandin E1. So you're going to give them prostaglandin E1 levels. Okay. The next thing is we're actually going to surgically resect it. So then wherever that little constriction ring is, we're going to cut that little constriction ring out and pull that out, and then end-to-end anastomosis of those situations. Okay, so coarctation aorta in the infantile type, keep the PDA open so you can perfuse the lower extremities. Even though they'll be cyanotic, you're still perfusing them. And so in those situations, give them prostaglandin E1 to keep the PDA open, and then surgically resect. In the adult type, we actually can go in and balloon open. We can actually take a balloon, we take a catheter, and we take and put a balloon in there, and then inflate the balloon to stretch open the constriction ring, and then we'll throw a stent in there. And if we throw a stent in there, you can actually get blood flow into the lower extremities. And if that doesn't work, you can actually, again, surgically resect and end-to-end anastomosis for that as well. So these are the things that we'll do for coarctation of the, but the big one I need you to remember is for the infantile type, keep the PDA open. How do you do that? Prostaglandin E1, and then you can resect it surgically. And then for the adult, you can either balloon, stent it, and then if that doesn't work, you can also surgically resect it. Okay, let's talk about the last particular finding here, which is Eisenmenger syndrome, that scary, scary thing that we want to try to treat these before we ever get to this, because if you get to this point, all of the surgical procedures are not going to be helpful, and the patient also ultimately will need to get a heart transplant. So let's talk about that one. All right, so the last one, Eisenmenger syndrome. So this is that, again, that scary, scary one that you don't want the patients to ever get to. Because again, if that right-sided pressures overcome the left-sided pressures, now you reverse the shunt, right to left. Now these babies got cyanosis. At this point, surgical procedures are not going to be helpful. Medical therapy won't probably be very helpful as well. At this point, you need to probably get the patients a heart and lung transplant. That's super sad, right? They're little babies, but what can we do in the interim to kind of get them that heart and lung transplant? Sometimes what we can try to do is, if you remember, what was the problem with Eisenmenger syndrome? Their pulmonary vascular resistance was son of a gun. It was so high, right? Because they're squeezing and their walls are thickening. What if I try to reduce the pulmonary vascular resistance so I can try to get some kind of like pulmonary blood flow through? What could I potentially try to help with that? I can give these patients pulmonary vasodilators. And that'll actually be things like, you can give things like milrinone or like sometimes inhaled nitric oxide, and that can just relax those vessels a little bit so you can actually get some kind of pulmonary blood flow. And that would potentially be somewhat helpful until they get the ultimate treatment, which is going to be a heart and lung transplant. Ninjas, in this video we talk about acyanotic congenital heart defects. In the next one we'll cover congenital. Hope you guys enjoyed it. Hope it made sense. And as always, until next time. you.